So I'll begin by acknowledging the traditional owners, the Gadigal people of the land we are on, and pay my respects to their elders. So it's my great pleasure and privilege to introduce a good friend and colleague, Professor Jaime Miranda. For those who don't know Jaime, he's really had a very distinguished career. Originally in Peru, he's from Peru, Latin America, has been in Australia, was here during the COVID period and somehow decided to come back. And now he's the head of the School of Public Health at University of Sydney. It's a big job to take, having not worked in Australia really, to actually take this on was a real big challenge. But he has a very distinguished career, and I'll just give you a few snippets. That he's also full professor in School of Medicine at the Universidad Peruana Cayetano Heredia. I don't know whether I pronounced that correctly, in Lima. He's professor of global health at the London School of Hygiene and Tropical Medicine. Also the Bernard Lawn Scholar in Cardiovascular Unit at the Harvard University. So he has multiple hats. Distinguished to the extent that he was named as one of the most influential researchers in the area of social determinants below the age of 40. So he arrived at it very early and has been featured in Lancet and Nature. His profile has appeared there. So you can imagine that he's made a big impact, especially in Latin America, but internationally in the world of epidemiology of chronic disease, not dementia in particular. That hasn't been his major focus. He's worked on obesity, hypertension, diabetes, and mental health. And fortunately for us, he's now actually moving into dementia. He's actually one of our investigators on the COSMIC project as well, really. So really welcome, Jaime, and we're delighted that you're here. And these are all people in our unit, so they really look forward to speak to you. And your focus is on the inequity in research, especially in relation to low and middle income countries. So, welcome.
Thank you.
Give you a bit of a spoiler there, sorry. There we go, that should be fine now.
That's all right. Thank you. Good morning, good afternoon, everybody. At least you had a chance to stretch your legs before this session, so I'm glad that that happened. And I'm going to make you stretch your legs again, so be prepared. Be prepared. Thank you very much for the invitation. It's a pleasure and an honor to be here. I've been here in Australia for 4 years. I arrived on a sabbatical in January 2020. I was a tourist in February 2020. In March, we sent the kids to school. In April, the kids went back home. And ever since, life changed. And living through a pandemic here, having the best of the world, seeing how you guys deploy a response, organize, and the structures, and also seeing Latin America was not only a personal, but also a professional lessons of how things work well or doesn't work well in a diversity of settings, and you'll see why. So now, I've started on this road as head of a school 6 months ago. So I tell people that I've been in Australia for 4 years, but I just mentally and emotionally moved 6 months ago because I wasn't here. My brain was elsewhere doing all this international work that I'm happy to share with you. So what I'm going to share with you has been influenced by the projects funded through these multiple agencies throughout multiple countries. And it started very early on with this opportunity to apply for one of the global centers of excellence in NCDs, funded by NIH. And the reason I put this story is because I put chapter 1 of my PhD into this, and we got it. So take risks, why not? It might happen. Certainly, given the recent trajectories, I am Peruvian, and I cannot start any of my presentations, particularly for public health and healthcare professionals and people working in research, without saying massive, massive thanks from the bottom of our hearts for all your work that you do, your contributions to society, and to make healthier populations and healthier societies. Let me go back. And And I cannot stop making this reflection as well of acknowledging the lands where we sit and the opportunity and how grateful we are to have the chance to learn from others, from the past, present, and future leaders, but also to understand context and to understand place and people. So I'm very grateful for the culture that allows us to thrive where we are today. I'm about yet to learn the names of the countries and the people, but that gratitude is extended to all of you guys and to all of them. I started my career in research, not wanting to do clinical medicine, but I will tell you that story in another presentation, perhaps. And I sort of gave myself this label of tranquility, of being the unfocused one. And out of survival needs, out of strategy, out of emotions, having an itchy feet, wanting to do things here and there. And when people ask me about impact, I tend to relate back to the people I was able to touch their lives on. And it is a great pleasure to me to say that many of those people have been people like you, people early in their careers with dreams, with drive, with guts to take challenges. And thank you for your perseverance and for your patience. And some of that avenues had took me to other spaces. And one of the most difficult spaces in my work career has been addressing the United Nations in a totally different forum, working for these guys. And I have to say, the motivation to keep learning from others, to keep doing what you're doing and contributing, is what drives my career. So I won't label myself as a specialist, mostly as a generalist, but a generalist who cares about people and putting a lot of emphasis on mentorship. And that's why I think I couldn't have made a career in the US or in the UK as fresh as I finished my PhD. I wanted to do many things other than specialize. Sorry if I'm sending the wrong message to this group. So most recently, we have delivered this report to the United Nations, and I didn't know I was going to be nominated by my country to sit there. I didn't know I was going to end up co-chairing this group of 15 scientists appointed by the UN Secretary General to inform on the progress of the SDGs. So a bit of a cherry. That is a fresh, brand new report, September 23 has been launched, an invitation for you to check it. And it's an invitation to embrace transformations so that we can achieve or get to its sustainable patterns and for society and for our planet. And what is the role of science behind that, and what is our contribution? Rather than delving into we are not making and we're not going to make in it, is to have the opportunity to address different audiences, from youth to policymakers, from governors and mayors to NGOs and civil society, to bring the science of innovation and the science of transformation behind that. So I have to remove my hat of being a public health expert, but to try to communicate that kind of more holistic view of development, of transitions, of innovation to those different audiences. So, and that has a price, because we as science, we're trained to write about our innovation, what is new. Whereas as generalists, you're unique, you have to make your message much more spread to a larger number of audiences. So if you ever had a chance, it's going to be utterly uncomfortable, but I invite you to take it. I cannot start my presentation. I still haven't get there. I keep saying I cannot start, so I don't know when you're going to see what you came to see. But my thanks to my team. I started this group 10 years ago, 13 years ago, and we had to answer this question 2 years into the show. What is it that glues us together? Why are we coming to work? Why are we seeing each other? And I think being back in Peru, generosity was a non-negotiable. We had to try, we had to care, we have to pass on what we had to younger generations. Innovation and quality, because you cannot do high-quality science without those two elements. And integrity, coming from Latin America, the word corruption sits next to us everywhere, all the time. So you want to make sure that you want to go home, go to bed, and sleep. Anyhow, I suppose this is a bit of a flavor. And this is the only slides that I will have on dementia. Then I have none. Why I'm here. In those reflections, I think by not being an expert, so I said I started my career in public health by living clinical medicine, Coming from Peru, tropical medicine was the option. HIV research, tuberculosis, malaria was where most of the strengths are, or epidemics or viruses were the other suitable ones. And I decided, no, well, let's try not to. And I ended up doing research in cardiometabolic health, then obesity, then nutrition, then mental health, and so on. And it turns out that we need to keep telling people to eat better, to do more exercise, and to have social capital, which are also the formula for happiness. And I think it's quite applicable for the prevention of dementia as well. Back in 2009, when I say I turned on the chapter 1 of my PhD as to why work on NCDs in an environment where most of the research is focused on infectious diseases, right? And in Latin America, most of the international research that you will see on forums will be on those particular conditions. Then I got these reviews say, the concern is that the proposed local investigators are quite junior. And I had that has been the largest rebuttal letter I had to write in my career, 56 pages. And the answer on this one has to be, put and simply, the truth, which is you can turn the country upside down and we don't have the people, so might as well take the risk. And they did. 10 years down the line, we were so busy working, and I didn't know that this was happening. We were so busy on survival mode, so writing grants, writing papers, participating in different forums, until someone from Nature Forum comes to do this interview. And because you're so busy, you're not looking at the forest, and you're not looking how much you're contributing. And it had to be someone from the outside to come and tell us this. That made me think, okay, we're not that bad. We're not that bad. And part of that formula of not being that bad has been always this strive to learn from others. To learn from others and to find meaningful contributions from multiple specialties, which is, I think, is the primary source for you guys working on dementia. It's a massive challenge. It's much needed for society, and our aging population needs better options. One of my tricks that I'm relearning on this phase of head of school, one of my tricks is, for surviving my previous role, was to have my own metrics of WTF did I do in the day, in the week, or in the month. I mean, I know I had to submit, I know I had to get money, I know I had to publish, I know I had to travel, but how can I make happiness out of that? And one of the signals of happiness for me working in that environment was whenever we were producing a grant and whenever we had any of these people working, every single one of them had to be able to tell the narrative, the storyline of that grant with their own words for their own fields. And if every one of them could elaborate that, we had a chance of winning. If not, we were not communicating, our reviewers will not understand. So I found pleasure on being challenged and being confronted by other specialties, and other people say, well, there's something missing here. And as I go here, I'm gonna rely on some of you, maybe you, to tell me, Jaime, shut up. Okay, so in 5 minutes before, let me know, because I'm not.
Yes.
I was telling this joke a couple of weeks, and not a joke, it just happened. I was in Sri Lanka working with a number of colleagues, and the chairman was from the UK, and as the time went by, he was getting more worried and more worried and more worried. And the guy from South Africa stood up and said, God gave the British a clock, but God gave us time. So, and I'm Latin, so God also gave me time. So, this is one of the slides that I sort of put on my career, say, I'm going to endeavor to try to communicate these concepts. And I did my master's in London. I was kind of middle, bottom, no, not bottom, but middle of the class, not kind of the most active. But I was falling asleep in one class, I remember, sitting in London in the auditorium. There was no smartphones back then, so you had to sleep. And someone presented this to me, and that sort of struck me as, what if we do something like this, right? So most of our training, understandably so, we think on the mentality of terrorists, right? Why don't we put screening before taking on the planes? We want to find where the risk is, right? So that mentality of risk because something's going to explode, that's risk. But that doesn't confront with preventing, like putting any of those suspicious artifacts going to the airport. So what else can we be doing? outside. And it's not the competency, but the complementarity. And we tend to forget the complementarity of both approaches. You may well criticize this graph in saying you're comparing oranges and potatoes. What is it had to do Kenyan nomads on the dotted line and London civil servants on the solid line? The graph is about systolic blood pressure. And the point is not to say one is better than the other, but the point is to understand that why are these two populations so different? If some of you work on cardiology and prevention, you will have learned the magic number of 140. 140 is when you cross the line to receive the label of hypertension. And where there's so many people with hypertension in London, but not so many in Kenya. And the answer to that question, let me go here, has to do with the determinants of the population mean. And this graph, the determinants of the population mean, has been so powerful in my career that informs many of the research areas that I work on now. So that a shift of the entire distribution is what we're aiming for, and that's our work of public health. If we do entire shifts in our population, there will be lesser people at risk on the group of risk, and there will be lesser people going through the declines we're trying to prevent, including dementia. Why does it matter for dementia? Why I brought that slide up here for you guys? Because many of these risk factors are shared risk factors for many non-communicable diseases, and many of these risk factors share the same graph that I presented you. So if we were to shift the diet, if we were to shift the entire distribution of populations, we will all be better off, including people we care. So I didn't know, all of a sudden I also became a dementia expert. So I was a mental health expert, a nutrition expert, a cardiologist, a nephrologist, and now, being a generalist, so it's my reflection. And on this reflection, and you know this better than I do, so 35% of dementia cases around the world seems to be explained by risk factors, right? Such as this, and that. You know this. Yet in Latin America, the percentages increases to 56%. Similarly, due to a combination of cultural, political, and economic factors, among others. And recently, the slide on the right, we were able to test that hypothesis. That's what we see, two different sources. This is 2023. To test that, how is the profile of disease and the patterns of disease that we see in Latin America? What is it has to teach us or to tell us? Which also links to the social determinants of cognitive decline as well, right? The causes of the causes, and again, linking back to that curve. So in this one, someone got called of a psychiatrist from Colombia who was quite savvy and quite itchy to apply new mathematical methods and machine learning to existing data sets. And he got into Nature Medicine a couple of months ago, and it was really, really nice to see something that was obvious for us. So the profile of the typical case of dementia that you see here in this hospital, beautiful hospital across the road, is not a typical case of dementia that you will see elsewhere. So I invite you to read that. It has lots of numbers, so I don't like that bit. It has lots of graphs that's somewhat understandable, but it's a nice contrast between populations, and even within Latin America, it's a nice contrast between very poor countries in Latin America and more developed countries in Latin America. And you can see the contributions of these macro determinants of well-being, including cognitive decline. And I start mentioning Latin America. I have to equalize what is it that we're talking about. So when people talk about Latin America, certainly we talk about the region that has had the fastest growth in population, and particular urban population in recent decades, right? So the urbanization process of Europe and the States and Northern Hemispheres and rich countries has taken years, hundreds of years. Whereas in Latin America has been so rapid, it's only what it was rapidly achieved in 4 to 5 decades. Much faster than Asia, much faster than Africa. Urbanization. Which one of you have been to Spain? Don't be shy, come on. Which one of you have been to Sevilla? Okay, is this Sevilla? Could well be. Could well be. That's a beautiful part of Lima where the Spanish set foot and established the government. But that beauty, if you look 180 degrees behind, that's the other side of Lima. Planned city, lots of poverty, urban poverty. And that's a reality where millions of people live through it. It's not that beautiful postal picture. This other picture is from Brazil. The reason I mentioned this in Brazil on my presentations is, what are the odds that for, you have to help me here with English, you have a sperm and you have what's a woman? Ovum. What are the odds for that combination of an sperm of an ovum were to fail, if we were to be the byproduct of that, were to fail only 10 meters apart? And that has such a powerful determinant, so that's living through inequities. The life expectancy is up to 13 years of difference, of being 10 meters apart. Inequities matters. Inequities kill people. Inequities kill our opportunities to thrive and to develop to our major capacity. So urbanization and inequities are some of the two labels that you will hear when people talk about Latin America. Yet, when I say let's equalize to each other, what do I think when people mention Latin America? And here's the other bit of the exercise. So I invite you to stand up again, and we have to do another exercise with me. Please stand up. And I'm glad that you're not on your computer, so thank you. I want you to use your hands. I don't know if this works in Australia. This works beautifully in Latin America. I've tested it. I want you to use your hands to point where your mother, how tall was your mother? My mom was this tall. I want to see if any outliers. There's one outlier there. Then I want to pinpoint where your grandmother was. My grandmother was here. Right. You say it doesn't change much. You say it doesn't work in Australia. Right. Thank you for that. Sit. The reason is that all these biological transitions have been experienced only within 2 generations. For most of the country, we're still experimenting that transitions. And I want you to focus. So when I make you to do this, I'm basically pinpointing to chronic undernutrition, right? We all have genetically the code to be as tall as, not necessarily as blonde as, but as tall as the Swedish, Nordic, you call Australians. Pick up your country. Genetically, we're not different. But what is it that we end up having these handicaps, right? Focus on this line, 30% year 2000. This is chronic undernutrition in children, year 2000. I am from the generation of the 70s. In my generation, that figure and that estimate was up to 50%. 1 in 2 of my peers would have experienced and survived and adapted to chronic undernutrition. I don't know what the figures are here in Australia, but that's, to me, when I think about Latin America and the capital, that's the human fuel, that's the human capital that we have to run our continent. If we were to replicate this study, or not the study, but this exercise in Tanzania, in rural Tanzania, we're also observing these handicaps. That's the global average in a white line, and rural kids in Tanzania are suffering through it. So we're living through it today. So the question is, do these handicaps carry into adulthood? And this is an important reflection because I want you to remember this part and invite you to make the effort to connect this to what does it mean for dementia, right? One of the words that I paid most attention for was after 10 years of working in the region, I put a lot of effort into writing this review. Why are we seeing such a rise of chronic diseases in our population? I'm going to tell you another story. The reason I speak English now is because I just quote unquote, just wanted to learn English to be able to read, guys, what you write. What you write in the New England, what you write in the Lancet. And I couldn't read. So I started learning English at age 20. How many of you have been to Peru? 2. How many of you have heard of Cusco? 3. Okay, Google it. That's where you learn English. Cusco is the touristic point of Peru. So lots of visitors, lots of people. And I thought I just spoke English, but in Cusco you don't learn English. You think you learn English. And what the journals and the books were writing is that people would have a stroke age 60, and I would look into my base of the patients, people with stroke were having 40s. I see what's going on. People with myocardial infarction would be on their 70s, and would look at me and say, well, but I'm not seeing that many myocardial infarctions. What's going on? People in the journal were writing about thrombolysis, and would say, well, our emergency is full with other things. More diabetic comas, people whose first episodes of diabetes were spread through all the way to intensive care because they didn't know they had diabetes. So that was part of the motivation to write this review, and we came up with this model, the capacity load model. And the capacity is the engine. I already gave you the exercise, how much we're not making to our full development, right? So it's the stressors that we have in utero and in early life that determines whether or not we accomplish, biologically speaking, our full potential. The example I give, let me be, I'm very practiced, so let me use this example. Not that I want to show off my cards, but let's imagine these are energy cards. And if I am a kid living in the Peruvian Amazon, and if I'm growing, the growing and survival is our transactions about energy, right? If I have malaria, I'd rather use that energy to counteract malaria and not to growth. If I have pneumonia, I use that energy not to die of pneumonia and not necessarily to growth. The organisms are so clever that it will maintain the most essential living organ, heart, lungs, not necessarily extremities. So most of our energy will go into maintaining. If you have food stress, you don't grow, right? Whereas if you are in Sweden or whatever, you don't have malaria, you don't have pneumonia, you don't have food scarcity, in general speaking, not saying that it doesn't happen. So you're able to accommodate most energy to the resources, to growth, and to biologically develop. Our populations are not developing to the full. So that's the capacity. So genetically, we have the biological engine to develop to full capacity, but we're not. And then it's the load. So we come into society, and then there's food, there's pollution, there's stress, there's diet, we're sitting in the computer. So we are challenging our biological engines, not necessarily to the best conditions of the environment. And what I say to my students is, if we were determined and biologically determined to be beautiful human beings as a species that we are, let's say a Ferrari, we end up being what? Pick up your choice. Some people tease me, maybe a Toyota, you're being generous. Maybe a bicycle or a tuk-tuk. So that helped, I'm a very visual person, and that helped me understand and bring together a lot of this. So we have a penalty, and our populations come into society with that penalty, and then we put all these other stresses, and that helps me to understand many of the problems that we have to play around. What does it mean for society? And there has been very good studies around human capital and how chronic undernutrition affects not only the immediacy of having negative child outcomes, but also in the longer term, poorer or lower or lesser macro determinants, such as how much money you make, what type of work you end up doing, whether the countries that you end up working on are more wealthier than others. And the visual example of that is this. So this is the brain of a 1-year-old who has experienced chronic undernutrition. And I think for this room, I'm going to assume that you know what it is. These are neurons. I got it wrong. That's the normal brain, and the new image is the image of a kid with chronic undernutrition. Grotesque. What other words can we use? Awful. Not beautiful. What other words come to your mind? Deprived. Another one? You speak English, guys. I can give you 10 in Spanish, but not in English.
There's a lack of connection between the neurons.
lack of connection. Yeah? We can argue there is plasticity at kids where there's some sort of recovery. But the imprint, the injury that happens in populations is so massive. And the question that I ask is, if this is happening on our brains and it's visible, we are seeing stunted kids, we're seeing stunted brains, we're not seeing the other started organs. Does that mean that we set to fail early in life? Does it mean that if something doesn't go quite well, we'll face failures or cumulative capacity being absorbed or overused, overutilized, overheated, etc. So our engines were going to fail and going to fail earlier. And remember, all these public health gains are not forever. This is a comparison, mostly, this is from this year, I think. Comparison of only OECD countries, developed countries and England is experiencing a reversal on the gains that they had in height of their child. Now the shortest child of the OECD countries, amongst the shortest, are in England. And they were used to be on top of the league. So these transformations, these changes, these biological changes happen and can be reversed at the population level. So be aware of that. How are we doing? I haven't even started with the research bit. I'm still in context. I'm in background. Okay, be patient, please. I said we're going to equalize. It took me a long way to equalize, and I hope that I managed to convince you that when we talk about populations, we're not talking about the same population. So please keep an eye and attention. What is the starting point? How are populations coming out of societies, and what risks or what determinants or what challenges they might face. When you look at your data, think about what's behind the data. I started saying Latin American unequal and highly urbanized, and then I posed the question, what do I see when I see Latin American? And a big chunk of my presentation until now has been to tell you about populations. This is the other one. Let's equalize. We're not talking about the same. When you talk about the health system, what activates on my mind is this. I don't know what activates into your mind. We can have further conversations later on. These pictures are not from Latin America necessarily, although I will bet 100% that they are. They can be anywhere in the world. But for visualization purposes, this is what comes to my mind. And when we say, oh, let's wait for the health system, or let's ask the health system to do something, it's not going to happen. So most of my work is trying to prevent people to go through these systems. That's why I focus on prevention. I'm going to give you even a better analogy. This is your grant. A hammock with air conditioning. We're going to offer something beautiful that is needed, that is wanted. Sometimes we're forced to write grants like that. Be careful. Context matters, right? Some people say, oh, we're going to add this on. You want to add it that way or not? The capacity of the system to absorb new things is very limited from where I come from. I'm not saying it's impossible, but let's equalize.
There was an air conditioner on top of that.
As well? As well. That's my office now. Head of school, you see? The first thing I asked as a very Latin person, he said, so Jaime, what do you want? He said, I have a laptop, I happen to say. And I said, I want a hammock. And the guy looked at me and said, what? And that's where I come from. I want a hammock. But you see, I'm testing my powers. So give me 10 years. So health systems, and I cannot talk about health system without ignoring what just happened over the last few years and the reason why I'm here as well. So you all, or what, some of us, or particularly I would like to see my country on the front page of large, prestigious, major, influential newspapers. So this is New York Times and Peru made it to the first page, but not for the right reasons. And I wish this was the World Cup. I mean, for me, World Cup is football, okay? Not soccer, football. So I wish this was the World Cup rank. Peru, number 1. Ecuador, Bolivia, Mexico, blah, 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 blah. Colombia, Paraguay, Brazil, Guatemala, a number of Latin American countries there on the list of the top 20 or top 25, I think, where the number of deaths exceeded what was expected according to prior years or average prior. Peru was more than 200%, I think. The Pew scores transformed that, but some national analysis said, we have observed, respective to previous years, 200% more deaths than it was expected, right? So it was hard. My dad died during the pandemic, my uncle, a cousin, directly or indirectly. I can name you 10 people. Everyone in Peru will tell you of close relatives and friends who died. The health system was set at capacity. Fortunately or unfortunately, I had the luxury or the unluckiness of tasting the best, the bitterness, the sourness, but also the best of this world. Being here in this country with the lowest mortality on the planet, but also seeing how people were dying. So when people talk to me about health systems, I say, hang on a second, we have to equalize. What is it that we're talking? These pictures made it to international news, but this is the Jungle Hospital where I did part of my training for 3 months. The day that I arrived, the guy left me on ICU and went on holidays. We had a problem. So what does it mean for health system? Let me try now bring this down closer to you guys. So now that we have made this equalization, where does our research fit, or how research fits to improve this? And as I said, I started doing research in cardiometabolic conditions, and I say, well, it's a problem of the patients, you know? They don't want to take their pills. And I thought, or we thought, oh, it's because our health system is broken, because you have to pay, because you don't have doctors, because you have to make appointments, etc. That picture of that graph is from the UK. Free healthcare at the point of delivery, GP practices nearby areas, people educated, a pharmacy with supplies in place. Within a year time, halfway through, around 50% of the people are not taking the medicines. So we have a problem. And it's not because we are poor, and it's not because we're ignorant. We have something bigger going on. Then flipping the same question to the other side. So if it's a term of access, so what does it take on the experience of someone having to visit the facility? So if you work on a minimal salary in Peru, that's around $200 a month, $300 US a month. Yes, it's not enough for your rent here, it's not enough for your coffee. We have millions of people working on around $200 a month. And you have to wake up at 4 a.m. in the morning to go to the hospital to pay. It's subsidized, but still you pay. You pay your transport, you pay for a hospital record, you pay for the appointment, and then you have to see a doctor, you have to come back another day to see a doctor, you have to come back another day, more transport, more expenses. For the doctor to say, we're trying to say what will it take to get a label of diabetes. So you have symptoms, let's say, for hypothetically, it's a case of diabetes, but you have to go to see a doctor. The doctor will send you a blood test. You have to go and pick up the laboratory results and make another appointment to see the doctor again. When you equate that time to cost, it amounts to 4 days of work. And if you are on $200 a month, you cannot forego 4 days of income. And that was one of the failures of the pandemic. Peru did one of the earliest close downs on the planet, but people couldn't hold the lockdowns for more than 10 days. There was no food. They had to work for the day. Then, if we were to overcome the obstacle of coming, I would say time, price, availability, etc., I love this study because it was a punch in the face or a kick on the whatever you want to be kicked. So people who will wait outside of the clinic consultation, outside of the cardiology appointments, and we ask 2 questions. A, do you believe that the medicines that you've been prescribed are going to be good for you? Maybe, you know, I might as well do. Do you believe the medicine you've been prescribed are going to be harmful? Yes. So despite overcoming all these barriers, people coming through our doors, outside of our doors, we're seeing these failures as well. And finally, and the social cohesion, social capital. And it's easy for us to say in a 10-minute consultation, despite all this order, oh, now you per minute you have to eat without salt, you have to do more exercise, etc. Food for us is very important. Food for us is a very cultural thing. And the fact that we have to cook something else for him means that you're separating him out of the family. So we tend to give this prescription out of context. All of these multiple punches makes me think, so WTF again. So what I'm going to do? Here I am in Peru with this population, with this infrastructure, with this history, with these challenges. Some of these challenges are unique to the system. Some of the challenges aren't necessary because we're here, are more globally. How do we go about our career? So have time.
10 minutes. I'm not sure if there's another person coming into the room, so.
Okay, because you're a scientist, I'm happy to share the slides with you. Go and download. You will read it. Let's go. Kick off. 10 minutes, let's see. Let me know at 8, please.
I will.
Thank you. This picture was from my colleague from Bristol. I moved back to the UK to write my PhD, and then he came back to visit me. And it's the most utilized, underpaid slide of my career. I should be giving him loyalties. We know it's a dog. It's a dog. It's not a tiger. It's not a cat. This dog has been accompanying me since my career, every single one of my presentations, because it motivates me to answer, to ask why or what. What's in it? What's in there? And give me that itchiness, that fright, say, I want to learn something. Is he 3-legged dogs or 4-legged? Does he have a long tail or a short tail? Is it patched color or is it uniform colors? I don't know. Is it a slobbery dog or not? And you put me like a dog, like, go and fetch, I will go towards that research question. I want to learn. I wouldn't start saying this is a dog, we need more dogs, or we need to look after the dogs. I think what drives me is what is in it for me to learn. And here I'm going to navigate you through some of these research adventures. Latin America, massive structure called the Andes. The Andes cut Latin America north to south, all the way from Colombia and Ecuador, and Panama over here. Peru is here. But it's a unique laboratory to see people living at 4,000 meters above sea level in the Andes, people living in the tropical Amazon, people living in the desert coasts, etc. So when people, lesson for you here is when you see any aggregates about Peru, don't believe it. It's not true. Sorry, you see? I also have my own. Don't be true, because who are you talking about? Are you talking about people in big cities and small cities? Are you talking about people in the Andes, in the mountains, people in the Amazon, people in cities in the Amazon or in rural areas of the Amazon? So we started with this study. The push for migration. Peru had an internal war in the 80s, and we were able to have migrants and non-migrants in a somewhat natural experiment. And we were able to follow these people over time. And when these people migrated towards the city, and we had a contrasting counterpart in rural areas, and we had the migrants. We know that there are urban-rural differences. How do migrants experience, embodied these changes through society? So we had, migrants had a higher risk of incidence for obesity. The rural people had a higher risk for hypertension, and the urban population had a higher risk for diabetes relative to the others. So even within these quote-unquote simple chronic conditions, risks aren't different. There's something going on that tells us that these populations behave differently. If any of you is interested in doing migration studies in Australia, you have a natural experiment going on here in front of your noses. Have a look. With that learning was one set, one region from the rural Andes moving into Lima, the urban capital. So to say, I show you the first picture of Latin America, that's only one part of the equation. What are these human-environment relationships, how they're portraying across other settings? So we did this chronic cohort study designed to test that question. To what extent do we have this difference not only in prevalence, but also this difference on incidence over time? It has been quite unique to tell us that rural stories is very different to urban, high altitude versus low altitude, people exposed to biomass versus not exposed to biomass, and so on. And again, we benefit from this uniqueness of having such an living laboratory in the country with many settings. I use that slide to say if I were to be Minister of Health in Peru, it would be a headache. Circles, the size of the problem, prevalence, bars, the coexistence of condition. The, how do you say it, the width, the bigger the width, or no, the larger the width, the more coexistence. So basically, I have 4 different countries in my own country. Is it I'm going to say one policy for the entire country? Is it going to pick up one, turn the others, etc.? So it's to instill, and again, that message, when you see country averages, make sure that you separate, particularly in settings where you have diverse populations, and particularly in settings with diverse geographies. I'm going to run through here because data pooling, thank you to Miranda for the invitation to join the team on the COSMIC project, and I think he learned about this through this collaboration. So one of my PhD students started doing this data pooling effort and was able to not only get acquainted with existing studies in the region, but also longitudinal studies. So research questions were tailored for the region. And again, the obesity incidence risk is different than is being written elsewhere. So, and again, context matters. Part of that work has informed many other global initiatives, such as this NCD risk. I'm proud to show this because our data from rural Andes was one of a few data points informed this. So, and again, kind of going against this, and for me, it was quite telling because I did my PhD working on rural areas. I knew something was coming, and being that not only reflecting your own studies, but also how that contributes to a message in larger initiatives was very insightful for me. Then, a subset of that, we did this 30-year trend analysis for Latin America. And this one, I'm particularly fond of this because what it takes to remove 1%. And again, let's go back to that graph of population shifts, right? And let's imagine that we have population shifts on people with money and people without money. What it takes to move 1% point prevalence in people with money, you can buy better food, you can go to the gym, you can go to the doctor, etc., is going to be entirely different to what it takes to move 1% point prevalence in people without money. Your strategies are going to be entirely different. What we did here is to understand where in the transition we are before the socioeconomic gradient hits obesity. The story of obesity is hits the poor. And when it sits on the poorest people, it's going to be much expensive, much difficult, much harder to remove that point prevalence. That's why we did this study. And then, when I run through here, urban health, another collection of data pooling efforts. Data exists if you have the patience to get around it. So here's a message for reminder patients again. It took us 3 years to harmonize this data. What a painful job. 3 years, just checking, understanding, and now we're seeing the products. And what we learned, 356 cities from the region, and we say that what is being written about the associations between urban living and the built environment, Latin America has a different story. Our urban living is an unplanned, rapid growth without resources, very, very cohesive or crowded. Crowded is a better word, etc. So when you read the literature about urban living, that people, it looks like the more resources you have, the better off, or you're better off in the cities. In Latin America, it's not necessarily that way. The intention of the big arrows is to say this is a unique example. This is what the literature writes. This is what we find against.
I'm just going to check it is time. I'll check if anyone else is coming into the room. If not, we've got a little bit of leeway.
Don't worry, I'm going to make it. I said I was going to rush through because I would like to hear your question. I like this slide because as a similar one, when I show you the Brazilian picture, if you're a female being born in Santiago de Chile, the inequalities are so poignant that there's a 17? Almost 18 years difference in life expectancy. Inequalities kill. And the ecogenic effect. Most of the directions or most of the literature said if you have access to green areas, you're better off. Actually, if